Very good morning. My job today is to think about adults with ASD. I think most of you who are working with children with ASD are not thinking about it yet. So it's an opportunity for us to start thinking about it. And first of all, we need to wonder why we really need to think about it. The prevalence studies in India are quoting a much lower number than what the CDC is saying, probably because of the way we are studying prevalence, the samples and so on. But we know even a conservative estimate suggests that about every year, given our birth rates, about 2,500 children will be diagnosed, will have autism spectrum disorder. And if we think about a true estimate, it's likely to be about 5 times more. So about 7,500 children on average every year is likely to be suffering from ASD. And if you multiply that number by 12 or 15, you get a huge number over the next decade who will likely be suffering from ASD, and hopefully we will identify and intervene them. So when we look at the next decade, we will have a lot more adults who will have this problem, and I'm not sure if we have an answer, if we have services organized. And this is not just a problem we have here in India and Tamil Nadu, but it's a global problem, as you will find. So this is the overview of how I'd like to proceed with the rest of my talk. Firstly, I'd like to look at what the outcome studies are predicting. What can we expect out of the kids who are in our own programs, and what's likely to happen for them? And before we look at the challenges, I'm always interested in understanding, the neurological basis which predicts these challenges, and then to look at where we are at this moment in terms of our treatment approaches. Now, this is a study which was done in San Francisco. Why am I talking about a study which was done there? It's because of the robustness of this study. This study was done in that district, and it had a number of about 6,970 children between the age of 2 to 14. So any child who was born between 1991 to 2002, who was in their records, were included, and had ASD, of course, were included in the study. And what they did was they followed these children up, into their early teens and adulthood, and looked at what happens to them. Now, what really started happening was, there were different trajectories. I'm going to really try my luck to see if the pointer works, and that's my training today. You can see there are about 6 trajectories, I think, in this, and you will see they plotted this graph for each main domain, the communication domain, the stereotypes, and so on. And if you look at this graph, the severity of the presentation predicted the outcome. So if you started being low functioning, the chances are higher that you will end up being that. But there was one particular group which you can see goes up and goes over the graphs which are above them, which is called the bloomers. These were people who bet the odds and actually did better. And then if you look at the social trajectory, again a very similar pattern. The people who started out at the bottom remained at the bottom, but there was, and again, a group of bloomers who went up. And if you actually try and total the number of people in the high functioning bloomers, it's about 20%. And if you include the medium high, it's about 50%. So about 20 to 50% seem to do better, but then there's a whole lot of group who actually don't do as well. And when they plotted the graph of the repetitive behaviors, it was very different compared to what they found in the other two. This was more like a flat curve. There's hardly any improvement. But the saving grace was for about 25% of children, they did not have and they never developed. There was a group which worsened and there was a group which improved, but it was more or less flat. This is really useful for me to think in adults because one of the key challenges I find in adult patients with ASD who is sometimes even reasonably high functioning is that the problem is coming from the repetitive behavior. And what did they conclude from this study? They found that the symptom severity generally predicts outcome, but it's not always the case. Bloomers are those people who had a higher IQ, higher maternal education, and were from a dominant culture. Now, this to me highlights the role of the mother. The fact that high maternal education from a mainstream culture is a predictor for, better outcomes, to me indicates what the mother is probably doing at home. And when we look at the other, home-based program studies, parent-mediated intervention for autism, we know that a capable mother who's got the training is likely to increase the number of hours of intervention. And we know if the number of hours of intervention can be about 20 to 25 hours per week, then the outcomes are far better. And if you look at the ESDM program, how quickly they expect improvement is far greater than what you would do if you were not using a structured program. And again, the high functioning and the bloomers were correlating across domains. I think this highlights the fact that the underlying neurological process, is similar in both conditions. Yet, just to keep our lives more complicated, it's not always straightforward. You cannot just predict. You'll have to keenly observe and support a child to sort of figure out on which of these curves they're likely to fall. So for those of people who are thinking, okay, this is a US-based study, what's the Indian study saying? This is a sample from India. You can look at that. About 80% became verbal in a follow-up of about 10 years. But of that, about 42% had just need-based speech. So they were just communicating what they needed. So these are people who can function in situations where there are people who can take care of them. For you to survive in the social life, you need a lot more complex communication. And only 25% had friends, and 46% were able to look after themselves in terms of their self-care. Again, lower disease severity, parent participation, higher maternal education was associated with better outcomes. Again, we are seeing a thread here that we need to be thinking about including our parents and having home intervention, because I'm starting to doubt if just therapy center-based intervention is going to be enough. I very much doubt. And this is from a round paper or roundtable conference which was held in Sydney in 2013, and it was conducted by Howland from the Sydney University. So they combined about 24 studies looking at adult outcomes all over the world, and obviously they're mostly from the developed world. Only about 50% actually completed school. 25% found a job, and even harder, those of us who are married know that that's probably the biggest challenge in life. It's not surprising only 5 to 10% were in a meaningful relationship. And I think the previous speakers quoted as well, if you look at the criteria of formal education, employment, living independently, and sustaining social relationships, only about 20 to 25% make that cut. So life is not easy as these children grow up, and we need to prepare ourselves to deal with them. So one of the things is, is not just, the neurobiological factors, the neurotransmitters, it's also how the society is set up. We know, those of you familiar with research in schizophrenia, the Indian outcomes are better than the outcomes in the developed world. The argument that I have in my mind is because our society is more accommodating. Somebody can, often I think the people with schizophrenia end up as watchmen for all reasons, or they can, run tea shops or do simple things and be integrated with the society. Whereas the more sophisticated and complicated your social structure is, the more difficult it is for these children to be included. And obviously the other issues are the carers get elderly as these people get into adult life. There's far greater social isolation. And I don't think there are many day programs. I think that's something that we need to start thinking now. In a decade from now, we will have lots of these children who need such programs. And paucity of respite and residential centers, which are very common overseas, is something we need to think about. Very briefly about the neurobiological stuff, which I like to think about, because I think it's in that framework everything else is happening. And if you look at this, these are the main structures. My apologies, I don't think I figured out how to work out this pointer. You can see the anterior cingulate cortex, focusing on mentalizing, the prefrontal cortex, which helps in social judgment, the amygdala, helping us with affect recognition. All of these are not working in sync. And again, lots of fMRI studies are saying these children get drifted into the detail without, getting the bigger picture. Their facial recognition and their gaze detection are not stimulating. But the good thing is, as in other formal models is, it's not like these will not work. They need a lot more stimulation. What's heartening is if we can stimulate, they seem to respond. That's the bad news here. And here it shows, the weak central coherence is a real problem. You can see these children drifting into these details and missing the bigger picture. When they come into adulthood, what I glean from this is that they miss the pragmatics, the bigger picture, and get, distracted by the actual literal words and so on. So that's something for us to keep in mind. And also when we're intervening, when we're using things like social stories and role playing, those open up their mind to look at the bigger picture if possible. And this is the triad of deficits, which says that the fundamental problem is with empathizing, which can impact on communication, social, and other domains. Whereas the strengths can be systematizing. This is where we can really develop their strengths, because they are very systematic. They understand the sequence, they just stick to it. And it's really important when we think about setting up vocational streams that these repetitive behaviors are channelized as strengths. Quickly on to strengths, to the challenges. You can see a whole lot of challenges which stem from these core symptoms, the physical, mental, challenging behaviors. And the one on your right are the functional domains. Because of these core deficits, they have a lot of functional domains and, of course, relationships. And there's a whole lot of communication-related problems, and understanding and empathizing and difficulty in theory of mind means navigating social space just a nightmare in unusual circumstances. To make it more complicated, they have a higher predisposition of physical problems, including sleep difficulties, which has been attributed to abnormalities in melatonin or circadian rhythm, GI disturbances, the seizure disorder. Studies show that if they have a lower IQ, they have a higher predisposition for seizure disorder, up to 25%, and higher metabolic problems. I'm afraid prescribing drugs is probably one of the reasons adding to this load of metabolic problems and degenerative disorders. Very, very recently, some of these adults have gone into an older age group. They're being followed up. There are studies indicating there may be a higher risk of Parkinsonism and so on. These are early studies. We need replication. So, something for us to remember. I think there's a whole talk on this. These people are having higher risk for mental disorders. Up to 50% can be anxious. I was just seeing a boy in my clinic yesterday. He's reasonably talented, but he doesn't know how to navigate a social space. So he was just waiting to leave my office, as I was talking to him. So you can understand why they would have high levels of anxiety. As they come to terms with their disability, they are prone for depression. And OCD is another very common problem. It can blend with their repetitive behavior and need for sameness. And I think there's another talk on ADHD. So these are very common ones that we need to be thinking about. And very high rates of self-injurious, destructive behavior as well. And I'll just mention, the repetitive behavior, because that's the commonest thing that people seem to want help from, in addition to some of these ones. I remember a mother bringing this boy who actually wants to sniff a girl's or lady's handbag. So you can imagine what can happen. So when he gets stressed, he becomes really focused on doing that. And he goes out of his neighborhood to do this, and it became a huge problem. The police got involved, the neighbors thrashed him, and it was just a nightmare to get this boy out of it. I remember another case where a boy with sexual disinhibition was sort of becoming predatory towards young girls, not knowing what's okay and what's not okay. And there was another instance where a boy really likes to ride a bike or his car. He obviously does not have a license, and he's now 21. So if they refuse to allow him to drive, he goes to the opposite house and breaks the car windshield of the opposite house. So, it gets really challenging. And this is where applied behavior analysis and functional behavior analysis plays a key role. And I think you should look forward to the afternoon presentation on that. Again, very poor rates of relationship. I'll just quickly run through the treatment approach. These are recommendations from Motley on what are the investigations that are useful, very similar to what you would do in children. Here it assumes that they come to your attention when they are an adult. Very key. The key thing here is to be realistic, keep the caregiver in mind. By the time they're an adult and they're seeking your care, the adult is burnt out, and you need to prioritize, individualize, and keep it holistic as possible. I mean, these are things that I try to keep in mind. Firstly, self-care and safety, then instrumental activities of daily living, tailored, individualized education, and then supported employment. If you look at the NICE guidelines 2014 on the evidence for treatment, there's only two things that seem to really have substantial evidence. One is supported employment works in this group. The second thing is fluoxetine for repetitive behavior. And I think you can have a look at it later. Again, on prescribing, for those of you who are here who are prescribers of medication, I'd just like to mention one point. Please do not ask these children to be on medication. Ask them to discontinue medication in 3 months if they don't come for follow-up, because I see people morbidly obese, having a lot more medical problems and metabolic syndrome and a bigger risk of violence if not followed up. To summarize, I think there's an increasing prevalence, probably because of improved identification. There's still less formal research and organization of services. We've got a greater need for support services. We need to engage the community by increasing the awareness. Overseas, they have ACT, but I don't think that'll work here. We start to focus on the strengths and support the families. Thank you very much.